بسم الله الرحمن الرحيم. Osteoarthritis by Professor Amir Youssef, Professor of Rheumatology at Mansoura University. Anatomy and histology. Normal diarthroidal joint, synovial joint, for example, knee joint. The articulating surface are covered by a smooth layer of hyaline cartilage and are enclosed in a fibrous capsule. The fibrous capsule merges externally with periosteum, tendons, ligaments, and fascia, and internally with synovial membrane, which lines the joint cavity. Articular cartilage is not covered by synovial membrane. A small amount of synovial fluid is normally present within the joint. This is the periosteum, and this is the ligament of the knee. Joint cavity contains synovial fluid here, fibrous capsule, synovial membrane, and this forms the articular capsule. Articular cartilage has low metabolic activity, no blood supply, no lymphatic drainage, and no nerve supply. Poor regenerative capacity. As you see, this is the joint cavity, the articular hyaline cartilage, and the bone. Historical considerations. Osteoarthritis occurs in all mammalian species. It is the earliest documented human disease. Human skeleton from 2 million years ago show evidence of the effect of osteoarthritis. What is osteoarthritis? Osteoarthritis is a degenerative joint disease occurring primarily in older persons. It is characterized by focal degeneration of joint cartilage and new bone formation at the base of the cartilage lesion, subchondral bone, and at the joint margins, osteophytes, as you see here. This is the healthy knee joint. This is the hypertrophy and the sparing of bone and the erosion of the cartilage. Osteoarthritis is not accompanied by any systemic illness. Epidemiology and burden of osteoarthritis. Osteoarthritis is the most common form of arthritis in clinical rheumatologic practice. Radiographic evidence of osteoarthritis is present in the majority of people over age 65, 80% of them over 75. Approximately 11 of those over 65 have symptomatic osteoarthritis of the knee. OA is associated with considerable burden, second only to cardiovascular disease, in causing severe disability. Classification of osteoarthritis. We have primary osteoarthritis and secondary osteoarthritis. Primary osteoarthritis or nodal generalized osteoarthritis, there is a strong inherited pattern. Number one, localized signs such as Heberden's nodes at distal interpharyngeal joint, as you see here, Heberden's nodes, Bouchard nodes at proximal interpharyngeal joints, as you see here. Generalized signs, 3 or more joint involvement or joint groups. All PIP in a hand is considered as a group, and later OA knee, hip, and apophyseal joints of the cervical or lumbar spine. Secondary osteoarthritis or premature onset osteoarthritis under age of 50 years affected any joint at any age. Occurs secondary to local mechanical factors such as trauma or meniscectomy, joint disease such as rheumatoid arthritis and septic arthritis, systemic diseases such as hyperparathyroidism, acromegaly, as you see here, ochronosis, which is accumulation of homogentic acid in connective tissue of the patient. Hemochromatosis is deposition of iron in the connective tissue and joints, causing secondary osteoarthritis. Risk factors for osteoarthritis. Number one, age of the patient. With advancing age, gradual loss of glycosaminoglycan from cartilage and leaving unsupported cartilage collagen fibers. This is the model of cartilage molecule. This is a protein backbone, as you see, and sugar side chain. Genetic factors may be present, especially in primary generalized osteoarthritis. Heberden's nodes denote generalized form of osteoarthritis. Both sexes are affected, but generalized OA is most common in women, especially after menopause, what we call most post-menopausal osteoarthritis. Mechanical factors, wear and tear. Accumulated microtrauma causes changes in subchondral bone that affects a joint's ability to absorb force of loading. This factor appears mainly in occupational OA, for example, OA of metacarpopharyngeal joints of boxes, knees of housewives, as you see here. This is OA of metacarpopharyngeal joints of boxers, and spine of coal miners, as you see here. Pathology of osteoarthritis. Manifested by fibrillation of the surface of the articular cartilage, as you see here. Clefts in the cartilage surfaces then develop, and eventually loss of cartilage can be seen. Start here and then cartilage completely destroyed. Subchondral sclerosis, marginal osteophytes, hypertrophy of the subchondral bone, and fibrosis and contracture of the capsule. As you see here, Capsule gaps in the cartilage can expand until they reach the bone itself. Synovial fluid leaks into cracks which can form in the bone's surface when this replacement cartilage wears away. This causes further damage and in some cases can lead to cysts in the bone or other deformities. If not treated, damage can progress to the point where the bones in the joints become seriously and permanently deformed. As you see, this is degree of severity of osteoarthritis. This is a normal healthy joint. This is a joint with mild osteoarthritis, mild narrowing of joint space. And this is a joint with severe osteoarthritis, complete destruction of articular cartilage. Clinical picture in osteoarthritis. The most common affected joints are knee joints, hip joints, lumbar vertebrae causing lumbar spondylosis, cervical vertebrae causing cervical spondylosis, hands, PIP with Bouchard nodes, DIP with Heberden's nodes, first carpometacarpal joint. In the feet, first metatarsopharyngeal joint. And the joints which rarely affected are ankle, shoulders, elbow, lateral metatarsopharyngeal joints of the feet. What is the symptoms of osteoarthritis? Number one, pain. Pain is aching and poorly localized and arising from several structures such as bone, synovium, ligaments, capsule, and muscles. It is worsened by exercise and weight bearing and relieved by rest. As disease progresses, pain during rest develops. Stiffness. Inactivity stiffness is a feature of osteoarthritis. It is not usually a prominent feature. When present, it lasts no more than 15 minutes. Limitation of movement, limitation of joint movement, and consequently limitation of the patient activity. Signs of osteoarthritis. Number one, swelling due to hypertrophy of subchondral bone, effusion, bony swelling or osteophytes, like this one, bony swelling due to formation of osteophytes. Muscle wasting, wasting of muscles acting on the affected joints. What we call it disuse wasting. For example, quadriceps wasting in knee osteoarthritis. He is measuring the circumference of the thigh at this point. Joint tenderness can be assessed using gentle pressure on the joint, as you see here and there. Joint palpable crepitus. Coarse crepitus can be felt when putting the palm of the hand over the joint during joint movement. Deformity. Squaring of hand due to involvement of carpometacarpal joint of the thumb. Flexion deformity of the knee. Genovarus deformity or bow legs. Flexion of DIP joint of fingers. Investigations. Laboratory features. All the laboratory tests are within reference range. ESR less than 40 mm per hour. Synovial fluid. Characteristic features of degenerative synovial fluid. Clear synovial fluid, as you see here. Good viscosity or positive string test. Synovial fluid, when dripped from the syringe, forms a string of greater than 10 to 15 cm. Inflammatory synovial fluid drips like water, forming small drops, such as in rheumatoid arthritis. Firm mucin clot, a test of synovial fluid precipitation in acetic acid. Slight increase in white cells, less than 2000 cells per cubic millimeter. Radiography. Asymmetrical joint space narrowing is characteristic feature in osteoarthritis, as you see here. Subchondral sclerosis, as you see there. Subchondral bone cysts, there, and osteophytes, osteophytic formation, here, there. This is a normal osteoarthritic joint, knee joint. This is arthritic joint with narrowing, asymmetrical narrowing in joint space. This is also a normal knee joint with equal space for both sides, and here arthritic joint with asymmetrical joint narrowing. Joint articular surface destroyed, as you see there. Narrowing of joint space. A large osteophyte spare. Narrowed joint space from thinning cartilage. Asymmetrical narrowing. Radiographic classification. Kellgren and Lawrence grading system of OA of the knee. 0, no change, normal. 1, doubtful. 2, minimal, minimal narrowing. 3, moderate narrowing. And 4, severe narrowing, as you see. The space is completely blocked. Cervical spondylosis and disc disease. There is narrowing of the interspace between 5 and 6 cervical spine, with osteophytes arising from adjacent bony margins both anteriorly and posteriorly, as you see there. The remaining intervertebral spaces and posterior articulations are normal. The term spondylosis refers to the formation of osteophytes in response to degenerative disc disease. Lumbar vertebrae advanced stage. This anteroposterior projection of the lumbar spine shows scoliosis and narrowing of the intervertebral spaces on the concave side, where extensive osteophyte formation is present. As you see, osteophytic formation, sclerosing of the margin. The osteophytes are thick and project laterally. Adjacent bony margins are sclerosed. Hips early disease. The left hip joint demonstrates narrowing with sclerosis and osteophyte formation adjacent bony margin. The right hip is normal. Here, right hip is normal, left hip osteophytic formation and narrowing of the joint space. Advanced disease of the hip, as you see, anterior-posterior view shows almost complete loss of joint space in the hip on the right that is associated with sclerosis, osteophyte formation, and extensive cyst formation on adjacent margin of the head and acetabulum. Completely destroyed hip joint. The hip on the left shows only mild sclerosis and the early osteophytic formation. Hand. There is irregular narrowing of all interphalangeal joints with osteophyte formation and sclerosis of articulating margins. As you see here, there. Subluxation has caused deviation at the distal interphalangeal joints. Similar narrowing and subluxation have occurred in the first metacarpophalangeal joint. First carpometacarpal joint, there is a marked narrowing of the first carpometacarpal joint space here with extensive sclerosis of adjacent bony margins. There, sclerosis. Osteophytic formation and subchondral cysts are present. Treatment of osteoarthritis. Goals of treatment: patient education, alleviate pain, optimize function, modify progression. Before treatment, you have to confirm the diagnosis, identify risk factors, assess function, assess comorbidities, assess patient goals. Current treatment of OA include patient education, physical and occupational therapy treatment, medical treatment, pharmacologic treatment, surgical treatment, and psychosocial treatment. Patient education. American College of Rheumatology guidelines for non-pharmacologic management of osteoarthritis. Number 1, patient education, psychosocial support, weight loss if necessary, aerobic exercise programs, physical therapy, and occupational therapy. Studies suggest that patient education is around 20% as effective as non-steroidal anti-inflammatory drugs and can have a synergistic effect with other treatments. Patient information and self-management strategies can empower patients to take control of their arthritis. What is the best method of patient education? Number 1, many patients do well with reading materials. if they can read and write. Some prefer attending lectures for patients, viewing films and other audiovisual presentations and websites. And also, it remains that still others learn best from one-to-one discussions. If the patients cannot read and write and cannot view films, we can give him the information by one-to-one discussion. I had a lot of new questions. This is some instructions for joint protection. Don't lie or sit too long in one position. Lose weight if you are overweight. Don't use low chairs. Don't stand in the same position or walk for long periods. Don't over-exercise the affected joint. Don't use faulty posture that places stress on the affected joint. Squatting position for knee OA. Don't load the joint when it is very painful. Does losing weight affect risk in OA? For a woman of normal height, weight loss of only 5 kg reduces the risk of OA by more than 50%. It is estimated that substantial weight loss, for example, obese to overweight or overweight to normal weight, could prevent 33% of OA in a woman and 20% in men. Physical and occupational therapy treatment. Therapeutic exercise in osteoarthritis. Isometric exercises or static exercise for strengthening quadriceps and glutei are important in reducing pain and disability from large joints, for example, osteoarthritis in knee and the hip. This is the isometric exercise, and this is isotonic exercise. Proprioception and standing balance are also improved, secondary to improvement in muscle strength. Exercises should be included in gradual program, increased gradually and tailored to the individual. However, vigorous prolonged weight-bearing exercise may worsen the articular cartilage and subchondral bone. An ideal exercise is swimming when done in a warm pool or hydrotherapy pool. Simple gradual home exercise program is readily taught and also effective. A specific exercise program plays a significant role in improving joint range of motion and function and reducing pain. Clinical studies have shown that a supervised program of fitness walking resulted in improvement of pain, joint function, and psychological well-being. Other physiotherapy measures include application of heat or cold packs, transcutaneous electrical nerve stimulation for pain relief, and mid-laser therapy or low-power laser. Rehabilitation and occupational therapy measures. Walking aids, crutches and canes contralaterally to the affected knee joint, as you see here. Walkers. Support pillows and splinting for carpometacarpal joint splint, this one. Cervical collars, knee support, and the knee support therapeutic tapping of the knee towards the medial side. weight relieving measures and splints. Again, lateral or medial heel widget insoles. Wear medially widget insole if they have lateral compartment OA. Wear laterally widget subtalar strapped insoles if they have medial compartment OA. Most of the OA patients have medial compartment OA. These measures are designed to relieve weight on medial compartment or lateral compartment of the knee by mechanically decreasing the varus or valgus torque. Shock absorbing insoles made of sponge or silicone. As you see here, this is the insoles, and the heel should be a little bit elevated. Medical treatment of osteoarthritis. Analgesics can be used, such as acetaminophen, paracetamol, clavinin or glivanan, flactophenine or idarac, central non-opioid analgesics, tramadol, conventional nonsteroidals, topical nonsteroidals, COX-2 inhibitors, such as celecoxib, local applications, capsaicin, corticosteroids, local injection therapy, symptomatic slow-acting drugs for OA. Diacerin, it blocks interleukin 1 beta, viscosupplementation, such as injection of hyaluronic acid. This is a suggested scheme for pain management in osteoarthritis. A patient with OA can start with acetaminophen or paracetamol 1000 mg every 8 hours as needed, or low-dose nonsteroidals. Combination of nonsteroidals and an analgesic is sometimes necessary during painful attack. Alternating treatment comprising 2 weeks of analgesic therapy followed by 2 weeks of nonsteroidals is recommended. Nonsteroidals with specificity for COX-2 may be considered for those at higher risk for GI ulceration and may be given with a proton pump inhibitor. Topical nonsteroidals are strongly recommended by the ECR, particularly for patients 75 years or older. Narcotic analgesics such as tramadol is indicated for acute exacerbation unresponsive to conventional therapy. However, it is preferable not to adopt a routine approach, but to adapt the prescription in accordance with the clinical course of osteoarthritis and the individual therapeutic response of each patient, bearing in mind the primary risk of GI and kidney side effects. Always avoid polypharmacy. Intra-articular steroid injection indicated for hot inflamed joint with effusion after joint aspiration and if no response to conventional nonsteroidals. Symptomatic slow-acting drugs of OA, Thiadoa. For example, chondroitin and glucosamine sulfate. Oral preparations of avocado and soya unsaponifiable. Diacerin, it blocks interleukin 1 beta. Viscosupplementation or intra-articular injection of hyaluronic acid. Efficacy of glucosamine and chondroitin. It is thought to stimulate chondrocytes to make proteoglycans. It is also thought possibly inhibit cartilage catabolic enzymatic activity. Combination of glucosamine and chondroitin may be more effective in patients with moderate to severe knee pain. Dose of glucosamine 500 mg capsule TID. Dose of chondroitin 400 mg capsule TID. And duration of treatment from 6 to 8 weeks. Diacerin is an anti-inflammatory medication that blocks interleukin-1 beta. Clinical studies concluded that diacerin had an effect in improving pain and slowing progression of osteoarthritis compared to standard treatment with non-steroidals or placebo. The most common side effect associated with diacerin was diarrhea. Dose 50 mg twice per day. Efficacy of viscosupplementation, intra-articular injection of hyaluronic acid. Hyaluronic acid is a glycosaminoglycan found in synovial fluid. It allows viscous lubrication at low loads and shock absorbency at high loads. Hyaluronic acid products had more prolonged effect than intra-articular corticosteroids. The overall conclusion supports the use of hyaluronic acid products in the treatment of knee OA. Surgical management of osteoarthritis. The decision to use surgery depends on the patient's level of disability, the intensity of pain, the interference with the patient's lifestyle, the patient's age, the patient's occupation. Indication for arthroscopy. Severe symptomatic OA that has failed to respond to non-surgical management. Evidence on clinical assessment of either loose bodies or mechanical symptoms such as locking, giving way, or catching. Total joint replacement or arthroplasty. Surgery is most often employed in hip, knees, OA, but may be helpful in OA involving carpometacarpal joint, metatarsopharyngeal joints, and less commonly the distal interpharyngeal joint and PIP joints. Approximately 90% of patients who undergo total joint replacement require pain relief and satisfactory function. Failure rates are variable from 10 to 30% at 10 years time. Psychosocial management. Psychological status of the patient with OA, including anxiety, depression, and social support, is an important determinant of symptomatic and functional outcome. Providing social support, even just regular telephone contact, can ameliorate symptoms. It is important to patients to know that OA is not invariably progressive. Many things can be done to them. The patients are not on their own. Future treatment for osteoarthritis. New techniques to restore articular cartilage. Autologous cartilage implantation. The grafting of cell populations derived from cartilage, chondroplasts, chondrocytes, undifferentiated chondrocytes. Autologous osteochondral grafting. It is a technique whereby cylinders of bone and autologous cartilage from a leather weight-bearing position on the distal femur are transferred into prepared tunnels on the articular defect of the femur. Also, somatic gene therapy. Somatic gene therapy is the introduction of normal genes onto cells that contain defective genes to reconstitute a missing protein product. Stem cell transplantation. Stem cells are undifferentiated cells that give rise to all of the body cells and organs. Three sources of stem cells: embryonic, adult, and fetal. Stem cells can differentiate and develop into one of the different types of cells that comprise the living organism. Thank you very much. Thank you very much for your attention.